What's going on with this person's toe? Highly likely it's an inflammatory process, and we can tell because of this swelling and how red it looks. My name's Dr. Anthony Wheeler, and I'm going to tell you everything that you need to know about pathology. In this discussion, we'll be focusing on inflammation pathology. Make sure you have your book handy for this, because this is one of the more involved presentations. There's a lot of nuances to make sure you have a grip on. So bust out your highlighters, your marking pens. Let's get ready to rock. Buckle up. Inflammation. Wow, this is a great image of inflammation because we have all the inflammatory cells and the granulation tissue, microvasculature formation, right? Inflammation enables fluid, plasma proteins such as complement, and inflammatory cells to leave blood arteries and reach the interstitial space. Inflammation is generally characterized as acute or chronic. So know those categories. Acute, neutrophils, and chronic, lymphocytes. Acute inflammation is associated with neutrophils and edema. You remember what neutrophils look like, right? Multilobated, usually 3 to 5 nuclei, right? If someone has vitamin B12 deficiency, they become hyperlobated, more than 5 nuclei. You remember neutrophils. You might call them a different name, polymorphonucleocytes. Those are still neutrophils. Look at all these neutrophils in this image here to the right. That's acute appendicitis. Call the GI doc. Call the GI surgeon. We might need to do a surgery to get that appendix out. Let's hope it doesn't rupture or anything. Acute inflammation is a reaction to infection to eradicate the organism or tissue necrosis, to clear necrotic debris. Acute inflammation has limited specificity, right? It just busts out haphazardly. Limited specificity. Acute inflammation is an immediate reaction and is part of innate immunity. Innate immunity includes the epithelium, mucus, neutrophils, mast cells, macrophages, eosinophils, those bilobed guys, basophils, those guys with a lot of granules, and the complement system. Let's discuss toll-like receptors. Toll-like receptors are special components found in the innate immune system cells. For example, macrophages and dendritic cells. Macrophages are the cells that go around and eat debris and other degenerating cells. Dendritic cells have these extensions that help pass signals and communicate to inflammatory cells to let them know what they need to recognize to get rid of. What are some of these markers? Well, CD14, which is a specific TLR, toll-like receptor. CD14 on macrophages is activated by pathogen-associated molecular patterns, or PAMPs, that are often shared by microorganisms. CD14 detects lipopolysaccharide, which is a PAMP on the outer membrane of gram-negative bacteria. When toll-like receptors are activated, NF-kappa B, a nuclear transcription factor that activates immune response genes and causes the synthesis of several immunological mediators, is upregulated, right? Because we want to make more of something. TLRs are also found on cells of adaptive immunity, such as lymphocytes, which are mainly associated with chronic affection. Lymphocytes, chronic infection. TLRs are crucial in the regulation of acute and chronic inflammation. Let's talk about arachidonic acid metabolites. Phospholipase A2 releases arachidonic acid from the phospholipid cell membrane, and cyclooxygenase or 5-lipoxygenase subsequently reacts with it. Now you must know this, because you will be asked. Prostaglandins are produced by cyclooxygenase. PGI2, PGD2, and PGE2 mediate vasodilation at the level of the arteriole and enhance vascular permeability. The mediator of pain and fever is PGE2. Got that? The mediator of pain and fever is PGE2. Also keep in mind that leukotrienes are created by 5-lipoxygenase. And neutrophils, right, our multilobated friends, are drawn to and stimulated by leukotriene B4 or LTB4. And keep in mind that neutrophils are attracted by 4 key mediators, which include leukotriene B4, also known as LTB4, bacterial products, C5a, and interleukin 8. Got that? All right. Now, vasoconstriction, bronchospasm, and increased vascular permeability are mediated by LTC4, LTE4, and LTD4. Now, wow, they all have 4 in them. But don't forget about LTB4 being for neutrophil attraction, okay? But for vasoconstriction, bronchospasm, and increased permeability, look for the 4s. Also note that those slow reacting compounds of anaphylaxis. Now we can't talk about immune acute inflammation without discussing mast cells. Do you know about mast cells? Mast cells are special immune cells with abundant granules. Mast cells are distributed widely across connective tissue. And mast cells are activated by tissue trauma, complement protein C5a and C3a, antigen-induced cross-linking of cell surface IgE. Okay? And activated mast cells immediately release of prefabricated histamine granules, which facilitate arterial vasodilation and enhance vascular permeability at the post-capillary venule. The delayed reaction is characterized by synthesizing arachidonic acid metabolites, mainly leukotrienes, which maintain the acute inflammatory response. And I know you're saying, Anthony, what about complement? Well, complement refers to serum proteins that support inflammation and are pro-inflammatory. Complement circulates as dormant precursors, but it can be activated. How? Well, there's 3 systems: the classical pathway, the alternative pathway, and the mannose binding lectin pathway. Those are 3 pathways that complement can be activated, and you know them because they spell CAM. And you obviously have a classical. If you have a classical, you have an alternative, just like genres of music. And then you have the weird one. Why is it weird? Because it's mayonnaise binding. Sounds like mayonnaise. Mannose binding lectin pathway. So you have your classic pathway, alternative pathway, and your mayonnaise pathway. But it's not really mayonnaise. No scientist wouldn't put mayonnaise there, so it's mannose, okay? Mannose binding lectin pathway. Let's discuss the classical pathway activation of complement, since it's classical. Now, no, it's not playing the grand piano, It's classical because it's different, right? It's classical because CI binds the IgG or IgM linked to the antigen. But in the alternative pathway activation of complement, this is complement that is directly activated by the microbial compounds. And the mannose binding lectin pathway occurs when mannose binding lectin binds the mannose that is present on the surface of microorganisms, which activates the complement. Complement activation eventually leads to C3 convertase generation, C5 convertase generation, and very importantly, the formation of the membrane attack complex, the MAC attack complex. C3 convertase mediates C3 conversion to C3A and C3B. That C3B joins to assist in the production of C5 convertase. That C5 convertase mediates C5 conversion to C5A and C5B. And that C5B, bear with me now, that C5B combines. What does it combine with? It combines with C6, C7, C8, and C9 to produce the membrane attack complex. The main products produced by the complement system include C3A, C5A, C3B, and the membrane attack complex. My editor, boy, I'm going to have a talk with him. Membrane attack complex. C3A triggers mast cell degranulation. C5A triggers mast cell degranulation and recruits neutrophils chemotactically. And C3B serves as an opsonin for phagocytosis. And the membrane attack complex attacks microbes, punches little holes in them, which causes them to lyse. Don't mess with the membrane attack complex. Hagman factor, also known as factor 12, is produced in the liver as an inactive pro-inflammatory protein. When Hagman factor is exposed to collagen, either subendothelial collagen or tissue collagen, it becomes activated. Activated Hagman factor stimulates systems of coagulation and fibrinolysis. Keep in mind that Hagman factor plays an important role in DIC, disseminated intravascular coagulation, such as DIC caused by gram-negative sepsis. Gram-negative organisms can activate Hagman factor. And when Hagman factor is activated, it activates various systems. Activated Hagman factor activates the coagulation system, the fibrinolytic system, and the kinin system. Regarding the coagulation system is responsible for coagulation, making blood clots. On the contrary, the fibrinolytic system is responsible for removing blood clots. And keep in mind that the final step in the fibrinolytic system is the plasmin-mediated cleavage of fibrin, which creates fibrin split products. And the kinin system, in that one, the kinin enzyme breaks down high molecular weight kinogen, HMWK, into bradykinin. and bradykinin mediates pain and causes vasodilation and increased vascular permeability. Make sure you got this slide down pack. You're definitely going to be asked this. The main signs of inflammation include rubor, calor, tumor, and dolor. What's rubor? Redness. What's calor? Warmth. What's tumor? Swelling. And dolor is Spanish for pain. Rubor, or redness, due to histamine, PGE2, and bradykinin-mediated vasodilation caused by relaxation of arteriolar smooth muscle. Calor, or warmth, due to histamine, PGE2, and bradykinin-mediated vasodilation caused by relaxation of arteriolar smooth muscle. Tumor, due to tissue damage and histamine-mediated leakage of plasma into the interstitial space from the post-capillary venules. And dolor, pain, is due to sensitization of sensory nerve endings mediated by prostaglandin E2 and bradykinin. What's going on in this image here to the right? You remember that? Can you see any signs of inflammation? Do you think this is warm or cold? Looks painful to me. Do you think the patient would say that's painful or not? Signs of inflammation. Make sure you have them down. Note that acute inflammation may be associated with fever. In response to pyrogens, macrophages release interleukin-1 and tumor necrosis factor, TNF. Interleukin-1 and tumor necrosis factor increase cyclooxygenase activity in perivascular cells within the area of the hypothalamus responsible for body temperature. The increased COX activity results in increased prostaglandin E2 in the hypothalamus, and that excess PGE2 in the hypothalamus increases the set point temperature of the body, which causes fever. So now you know exactly why a person with an inflammatory condition has a fever. Let's talk about our friends, the neutrophils. Neutrophils' role in acute inflammation. We know that neutrophils are the key cells of acute inflammation, right? That's why we're always asked, what's this acute inflammatory process? And we're given various options. Neutrophils on there and lymphocytes are on there, and it's obviously the neutrophils because they are the key cells for acute inflammation. Don't be tricked. Lymphocytes for viruses. Neutrophils for acute inflammation. Medical professionals like yourself must know the exact steps neutrophils take to mediate their effect. And we're going to talk all about it. This is probably the most important slide. The steps include migration, rolling, adhesion, transmigration and chemotaxis, phagocytosis, disposing of phagocytosed material, and resolution. Step 1 is margination. In the post-capillary venules, vasodilation decreases blood flow. Vasodilation makes it easy for neutrophils to stick to the vessel wall, opposed to being carried along with the blood flow, right? Step 2 is rolling. The neutrophils roll on the endothelial cells, those endothelial cells that line the blood vessels. And the endothelial cells amplify selectin. Selectin acts like speed bumps on the endothelial cells that causes the neutrophils to slow down. You must know the different types of selectins. That's the P-selectin and the E-selectin. And note that histamine is a mediator of P-selectin release from the Weber Pallady bodies. And tumor necrosis factor and interleukin-1 stimulate E-selectin. You also need to know what the selectins bind to. Selectins bind leukocytes sialyl Lewis X, and the rolling of the leukocytes along the vessel wall is the consequence of that interaction. In step 3, we have adhesion. TNF and interleukin-1 upregulate ICAM and VCAM. ICAM and VCAM are cellular adhesion molecules on the endothelium. C5a and LTB4 increase the expression of integrins on leukocytes. The leukocytes firmly adhere to the vessel wall due to CAM and integrin interaction. In step 4, we have transmigration and chemotaxis. Bacterial byproducts such as interleukin 8, C5a, and leukotriene B4 attract the neutrophils. Leukocytes travel in the direction of chemical attractants, hence chemotaxis, after crossing the endothelium of post-capillary venules. In step 5, we have phagocytosis. Opsonins IgG and C3b promote phagocytosis. Leukocytes create pseudopods that extend to form phagosomes, which are then internalized and combined with lysosomes to form phagolysosomes. Microorganisms or necrotic tissue are then consumed, hence phagocytosis. In step 6, we want to dispose of that phagocytosed material, okay? So the phagocytosed material can be destroyed in 2 ways, either an oxygen-dependent mechanism or an oxygen-independent mechanism. The most efficient killing method is the oxygen-dependent mechanism. Regarding the oxygen-dependent mechanism, the phagocytosed microorganisms are destroyed by the HOCl produced by the oxidative burst in phagolysosomes. NADPH oxidase utilizes the oxidative burst reaction to convert O2 into O2 minus. Superoxide dismutase, what a cool name. Superoxide dismutase converts O2 minus into H2O2. Myeloperoxidase, also known as MPO, converts H2O2 into HOCl, which is bleach. And this bleach is the main product that destroys the pathogen. HOCl, or bleach, is used within the phagolysosomes in order to destroy the phagocytosed pathogens. Wow, what a complex process. And this is going on all in anyone's body who's experiencing acute inflammation, if they have a normal physiologic response with no sort of immune deficiency. That's fantastic. Aren't you proud that you know medicine and all this science? I'm proud. I'm proud of you. I'm proud of medicine in general. This is great. You picked a great career. Oxygen-dependent mechanism. We're going to talk about that now. The oxygen-independent mechanism is not as effective as the oxygen-dependent mechanism. The oxygen-dependent mechanism occurs with enzymes that are in the secondary granules of leukocytes, such as lysozyme or major basic protein. Okay, let's get into step 7, resolution. Let's clear this up. As my girlfriend used to say, before she dumped me, oh, we need to talk. We need a resolution about this conflict. We won't go into that now. Anyhow, step 7, resolution. After the inflammatory stimulation has subsided, neutrophils turn into pus by going through apoptosis within the tissue and are no longer visible after 24 hours. Neutrophils' role in acute inflammation. Aren't you glad you're getting this down? We have leukocyte adhesion deficiency, Chidiac-Higashi syndrome, chronic granulomatous disease, and myeloperoxidase deficiency that we're going to talk about, because those are issues that affect acute inflammation. Leukocyte adhesion deficiency is an autosomal recessive defect in CD18 subunit of integrins. Clinical findings of leukocyte adhesion deficiency, no integrins, you're not going to adhese, right? Remember, we want those leukocytes to slow down along those walls, but if they're not adhering to slow down, we're going to have problems. What are those problems? Delayed separation of the umbilical cord, recurrent bacterial infections without pus formation, and neutrophilia. Let's talk about Chidiac-Higashi syndrome. Chidiac-Higashi syndrome, an autosomal recessive protein trafficking defect that causes impaired phagolysosome formation because of faulty microtubules. Definitely going to be asked about this condition. Clinical findings of Chidiac-Higashi syndrome include albinism, because melanocytes have abnormal microtubules to pass melanin to keratinocytes. Peripheral neuropathy, because the abnormal microtubules cannot pass nutrients to distal neurons. Pyogenic infections, neutropenia, neutrophils with giant granules under the microscope, you'll be able to see that, and abnormal primary hemostasis. Another condition to be aware of is chronic granulomatous disease. Chronic granulomatous disease is due to autosomal recessive or X-linked NADPH oxidase deficiency that results in poor oxygen-dependent destruction of pathogens. Clinical findings of chronic granulomatous disease include recurrent infections by catalase-positive organisms. Examples of catalase-positive organisms include SNAPS organisms, Staphylococcus aureus, Nocardia, Aspergillus, Pseudomonas cepacia, and Serratia marcescens. Make sure you have that. There's a specific test for this that you need to be aware of. The nitro blue tetrazolium test is used to screen for chronic granulomatous disease. If NADPH oxidase can convert O2 into O2 minus, that would be normal, the nitro blue tetrazolium test will turn blue, signifying normal result and proper function. If NADPH oxidase cannot convert O2 into O2 minus, that is abnormal, and the nitro blue tetrazolium test will remain colorless, signifying an abnormal result and improper function. So if it's blue at the end of the test, it works. If it's colorless at the end of the test, we have problems. Poor O2 dependent killing is a hallmark of chronic granulomatous disease. Now let's talk about myeloperoxidase deficiency. myeloperoxidase deficiency, which results in increased risk of fungal infections, right? For example, candida. If you have MPO deficiency, likely to be infected by candida. I'm not talking about our neighbors to the north. I'm talking about that fungal infection that causes people's tongues to look white, right? Candida. Myeloperoxidase deficiency results in defective conversion of H2O2 into HOCl. The NBT test, nitro blue tetrazolium test, will be normal. It will turn blue in these patients with myeloperoxidase deficiency. Now here's an important cell to be aware of. It's the macrophage, also known as giant eater. Macrophages and monocytes are the similar cells, okay, but they are called differently based on their location. If they're in the blood, they're called monocytes. And if they're in the tissue, they're called macrophages. Macrophages arrive in tissue by the way of processes of margination, rolling, adhesion, and transmigration of phagocytosed organisms aided by opsonins, and then degrades the phagocytosed material utilizing enzymes such as lysosome and secondary granules, and that's oxygen-independent killing. Regarding their timeline, 2 to 3 days after inflammation starts, macrophages reach their peak numbers. Interleukin 8 produced by macrophages attracts more neutrophils during prolonged pus production during ongoing acute inflammation. Macrophages may also create anti-inflammatory cytokines like interleukin 10. Interleukin 10 and TGF-beta also promote wound healing. Macrophages deliver antigen to activate CD4 helper cells, helper T cells, which release cytokines that support chronic inflammation response. Fibrosis is mediated by macrophages via fibrogenic growth factors and cytokines in an abscess and acute inflammation surrounded by fibrosis. Then chronic inflammation. Chronic inflammation characterized by lymphocytes and plasma cells as the dominant cell types are present in the tissue. Chronic inflammation is a delayed reaction. Chronic inflammation is more targeted, specific, and it's considered adaptive immunity. Here we have an example of chronic inflammation in response to a bacterial infection on the right. Is that bacterial? Stimuli that cause chronic inflammation include chronic infection, viral infection, autoimmune illness, foreign body material, mycobacterial infection, parasitic infection, helminth infection or worms, fungal infection, and certain malignancies. We can't talk about chronic inflammation without talking about T cells. Progenitor T lymphocytes are produced in the bone marrow. T lymphocytes continue to grow and learn and become educated in the thymus. In the thymus, progenitor T cells undergo T cell receptor rearrangement and become CD4 positive helper cells or CD8 positive cytotoxic T cells. T cells employ the TCR complex, TCR and CD3, to monitor for antigens. An antigen is recognized by the TCR complex and is displayed on MHC molecules, major histocompatibility molecules. There's MHC class 2, bearing the CD4 positive T cells, and then there's MHC class 1, bearing for the CD8 positive T cells, right? Antigen/MHC complex binding and a second signal are necessary for activating T lymphocytes. CD4 positive helper T cell activation, okay? Antigen presenting cells express the MHC class phagocytosis process and present extracellular antigens such as a foreign protein or APCs. A second activation signal is produced when CD28 on CD4 positive helper T cells binds to B7 on antigen presenting cells. Two subgroups of activated CD4 positive helper T cells produce cytokines that assist with inflammation. The two subgroups of CD4 positive helper T cells include T helper 1 CD4 positive T cells that help the CD8 positive T cells, and the T helper 2 CD4 positive T cells that help the CD4 positive B cells. T helper 1 CD4 positive T cells that help CD8 positive T cells. Okay, let's talk about them. T helper 1 CD4 positive T cells secrete interleukin 2. Intracellular antigen is processed. Intracellular antigen is presented on MHC class 1. Interferon gamma, IFN gamma, are secreted by the subset macrophage activator. T helper 2 CD4 positive T cells that help CD4 positive B cells. The T helper 2 subset secretes interleukin 4, interleukin 5, and interleukin 10. Interleukin 4, which promotes B cell maturation into plasma cells and class switching to IgE and IgG. Interleukin 5, which promotes the chemotaxis and activation of eosinophils. And interleukin 10, which inhibits the development of T helper 1 phenotype. Regarding T cells, cytotoxic T cell activation with CD8 positive T cells. All nucleated cells and platelets express MHC class 1. MHC class 1 processes and presents intracellular antigen derived from proteins in the cytoplasm. From CD4 positive T cells, interleukin 2 is released from the cell, leading to activation. The cytotoxic T cells are activated, and the CD8 positive T cell killing happens via perforin and granzyme. Perforin, as we know, makes holes in the target cell so granzyme may enter and trigger apoptosis by activating caspases. Fas-L expression activates apoptosis by binding to Fas on targeted cells. Let's talk about the B cells. Bone marrow produces immature B cells, which go through immunoglobulin rearrangements to become naive B cells expressing surface IgM and IgG. Receptor binding triggers the activation of B cells. B cell activation can happen three ways, which includes IgM binding, IgD binding, or MHC class 2 to CD4 positive helper T cell binding. Regarding IgM binding, surface IgM binds to an antigen on immature B cells. The immature B cell matures into a plasma cell that secretes IgM. Regarding IgD binding, surface IgD binds to an antigen on immature B cells. The immature B cell matures into a plasma cell that secretes IgD. MHC class 2 to CD4 positive helper T cell binding. Let's talk about that for a bit. Presentation of B cell antigen by MHC class 2 to CD4 positive helper T cells. The helper T cell CD40 ligand attaches to the CD40 receptor on the B cell, generating a second activation signal. The helper T cell releases interleukin 4 and interleukin 5, which mediate B cell hypermutation, isotype class switching, and maturation of immature B cells to become mature plasma cells. Wow, B cells. Look at this image to the right. If you know what type of cells those are, I'm very proud of you. I'll give you a second to think. If you don't know off the top of your head, you can read in the figure description. Multiple myeloma. Now you should definitely know what types of cells are abundant in multiple myeloma that classify this disease. If you're thinking plasma cells, because that eccentric nuclei, they're pronounced perinuclear HOF due to the Golgi apparatus, then I applaud you. Here. You are on the right track. Let's get going. We got this. Granulomatous inflammation. Okay, let's talk about that. Granulomatous inflammation is a subtype of chronic inflammation. Granulomatous inflammation is commonly referred to as granulomas. Wow, who'd have guessed? Granulomatous inflammation is characterized by epithelioid histiocytes. Epithelioid histiocytes are macrophages with rich pink cytoplasm. Granulomatous inflammation is frequently associated with large cells, so large that we call them giant cells. And those are usually surrounded by a ring of lymphocytes. Subtypes of granulomatous inflammation are classified as non-caseating or caseating. And you know this because we already talked about necrosis. And you know all the important types of necrosis to be aware of, right? We talked about it, the mummified necrosis, liquefactive necrosis, if there's a thrombi obscuring the blood flow to the brain, right? You know about necrosis, TB, right? The steps in the creation of a granuloma include macrophages process antigen and deliver it to CD4 positive helper T cells through MHC class 2. When macrophages interact, they produce interleukin 12, which causes CD4 positive helper T cells to develop into the T helper 1 subtype. The T helper 1 cells release interferon gamma, which causes macrophages to differentiate into epithelioid histiocytes and giant cells. Now to the right, this image here, take a great look at it. You should be able to recognize in the center there the necrosis, and around that you should be able to see some larger cells. If you are looking at the perimeter of that more pink area, you should be able to see the giant cells. Okay, so caseating granulomas have central necrosis. Non-caseating granulomas do not have central necrosis. For example, sarcoidosis is an example of non-caseating granulomas. But for caseating granulomas, like we're talking about right now, common causes of caseating granulomatous inflammation include tuberculosis, which you will definitely see, and fungal infection, right? So as a pathologist, I would order immediately an AFB stain and a GMS stain. Why? Because I'm looking for TB and I'm looking for fungi. Also, I would check their microbiology to see if they have any labs or cultures growing. Common causes of non-caseating granulomatous inflammation include sarcoidosis, Crohn's disease, cat scratch illness or cat scratch disease, beryllium exposure, or foreign body material response. The image to the right here shows a non-caseating granuloma. We know it's a granuloma because we have a number of giant cells and this amorphous eosinophilic material, but we don't have any central necrosis. That's why we can say it's a non-caseating granulomatous inflammatory process. Wow, I know that was dense. You might have to go through this one twice. There are a lot of cellular mechanisms, interleukins, and cell factors and signaling pathways that you should be aware of. It's not super high yield. There will be a few questions on it. There will definitely be questions on necrosis and sarcoidosis, but at that interleukin level, you might not see too much of that. But if you're a type A person, or if you're just going for complete glory, you might want to rewatch this one. Make sure you have your book, you've marked it up, you've made your notes. This one was a dense one, so if you made it through, I'm proud of you. And I will see you on the next one. Good luck. Keep studying. You got this.